received erythropoietin. And another comment that in the United States, the FDA has not approved erythropoietin for use of decreasing red cell transfusion in cardiac surgery. So my question is why do you think you found the results that you did, and that of not an increased risk for thrombosis? Is there some way you managed the patients differently, anticipating that this might be a risk of a complication?
Good question. It was a surprise to us as well to find no complication at all. It has been reported a few minor complications such as rash, cutaneous, and dizziness and fatigue, and a low incidence of thrombosis. So we expected to find some around maybe 1%. As I said, we had absolutely no adverse event. One possible explanation, or possible pitfall of the study is that we ended the follow-up on day 4. So if something has happened after the discharge, I can tell you now confidentially that nothing has happened, because in Italy usually the patient comes back to you whatever happens. Nobody's come back. But we could not exactly ascertain this.
Okay, my final question pertains to cost. Another concern for the use of erythropoietin is the cost of administration. You were unable to demonstrate a cost benefit to the use of erythropoietin in comparison to reduced red cell transfusion. There's data to suggest that patients who receive red cell transfusions have a longer time on a ventilator postoperatively, increased infection rate that needs treatment, and prolonged ICU and hospital length of stay. Can you speculate on whether or not, if you included the cost of morbid events related to transfusion in your modeling, do you think there would have been a cost benefit to the use of erythropoietin?
Yes. Well, I'm sure if we extend the cost analysis to complication, this protocol could become convenient, but I stick to the simpler approach. And cost effectiveness was a kind of analysis we performed after it was declared, but we usually in Italy we do not spend too much time on cost analysis, because you know the government is paying for everything. But so it's a different approach than that in the United States. But on further analysis, the protocol moved patients back from one unit. So if people used to transfuse one unit, they went into no transfusion category and so on, and failed to demonstrate efficacy in the over 3 blood units subset. Even if there was no difference in terms of length of stay in hospital, so I can't say there is a direct evidence of cost enhancement of this kind. If we put everything together, it will probably become convenient, yes.
Thank you very much.
Microphone was.
Malco Geneva. At least experimentally, there are some literature indicating that high-dose erythropoietin in a peri-ischemic model are brain and heart protective. So since you have a big cohort of patients, did you look at this issue?
Well, I know these studies, but it could become, when I planned the study, I tried to keep it as simple as possible, with a very clear and primary endpoint and simpler secondary endpoint. The studies in literature usually fail to demonstrate statistically the evidence of protection. So I didn't want to get into the difficult topic, so I don't have this data. Thank you.
Can you comment on what you use for your antiplatelet therapy post-operatively, and how did you assess for myocardial ischemic or infarction events?
Yes. We follow the guidelines, the European guidelines for antiplatelet medications. So we use 100 milligram of salicylic acid since day one for the patient without previous cardiac events, and we used an association of aspirin and clopidogrel when myocardial infarction or ischemia has happened 5 days before surgery.
Microphone 7.
Your hemoglobins were quite high. Have you tried to separate out your patients in each group to see if the patients who were anemic received some benefit from the EPO versus the whole group with their hemoglobins of 134 or whatever your average was?
Yes, absolutely. The subset of patients below 9 gram per deciliter was the subset having the highest benefit from the protocol. The protocol does not give a statistical significance on day one. You see, we collected the analysis, but I didn't speak about that because there was no difference. But it shows difference on day 4, and the difference is proportional to the starting point. So yes, the subset who has the most benefit is the one starting with low hemoglobin.
Are there any other questions from the floor? If not, thank you very much. We will take about a 10-minute break. And we will reconvene promptly at 5:05 for what I'm sure is going to be quite an interesting debate.